Thank you for 4 wonderful presentations. We have a little under 15 minutes for questions and discussion. And go ahead and you were quick to the microphone in the middle and go ahead and take your question.
My name is Nicole Shilla, and I wanted to offer my experience in California at the time that the law was passed. I'm not currently practicing in California, and to offer a question regarding that. I was working in a large health system in San Diego at the time that the law passed. I had recently completed my fellowship in hospice and palliative medicine. And the formal position of the institution was to be neutral and to allow each physician to decide whether or not to participate. And what I experienced in actuality was palliative medicine is really not a solo endeavor, physician only. And the law is very clear, I read it start to finish, that, let me state, I am not a proponent of the law. I believe very strongly that patient autonomy is not the arbiter of right and wrong, and in an absolute way. And I believe that the law clashes with my understanding of medical principles of medical ethics. And so while the law is very clear that no person, no physician is obligated to participate at any level, the reality of practicing within an interdisciplinary team it was quite a different experience. And I was curious, I was listening on Stanford's policy about, when attending MD refuses, a social worker navigator leads the patient to a provider who will participate, and the idea of having a willing consultant physician. And I just wonder, and I'm very concerned about having any institutionalized policy how you can have a true policy on an institutional level and truly respect the conscientious right of any provider to not be involved at any level, including referral. So I know we're talking in the present day and people in leadership are making decisions for the here and now. My worry is what we're setting forth in the future. And I ultimately left my position over these conflicts, and I moved out of the state. And I'm not saying that was right or wrong, and with a lot of real heart searching on it, but I didn't quite feel that there was a place for me in that system. So I want to say that, and what we're creating is going to go forward in the future and future providers. So any policies that we create now have big implications for going forward. So I wanted to say that. Thank you.
Thank you for that, Dr. Sorrell. I really appreciate just hearing your voice. I think it's an important one. I didn't put up there, because we have a range of views within palliative care, not just amongst our physicians, but our social workers, our nurse practitioners, our chaplains. The ethics department, as part of the process, had actually surveyed all physicians, nurses, and social workers. And so what I didn't put up there was we have an entire policy separate dedicated to conscientious or moral objection. That's in general, but we also use that and refer to that in our policy that the law is very clear that participation in any part is voluntary. And so I think, and we have a range of providers where they choose not to participate at all. And so we have space for that. It was important that we had that dialogue. And I think that it is important in terms of how the institution sets forth policy and that process. We spent a lot of time amongst these different discussions as to how the language would be framed, and in the context of the policy that we have the explicit statements around participation, that it is not required, and that this is a role. It is not placed upon disciplines as a result of your identity in that discipline.
Thank you. Scott?
Thanks all for not only wonderful presentations, but for being so thoughtful about implementing these difficult processes. Sorry, is that better? Yeah. Okay. So I think all of you touched on the theme of no individual wanting to be the go-to provider. And sort of at first blush that makes sense, but I'm curious about this. And in many ways, it's a suboptimal strategy. In fact, Steve pointed to this specifically as the world would sort of be a better place if we could identify some go-to clinicians. And I wonder what the source of this is. So I think about, I'm a critical care doc, and I've taken the role in my group for being the one who comes in at night and manages patients who are going to donate organs after circulatory determination of death, because it's a very nuanced process. There's no way that there's enough of it happening for all of us to be experienced. When the Ebola scare happened, a few of us volunteered and said, there's just no way every one of us is going to get trained to put the suits on, take the suits off, all the usual precautions. I understand that this is morally charged, but this isn't, these are people who are willing to do it at least some of the time, so it can't be a conscientious objection. So if there are people who are willing to do it some of the time, what resources do you think may be needed to support a couple people to do it all of the time, or at least for all of the patients? Because it's unambiguously an optimal strategy.
Yeah, well, thank you, Scott, for that. I should say that there are doctors who are willing to be the go-to. They're just not at UCSF. So there is a physician in the East Bay, Len Shavelson, who does this, and we've referred patients to him. And there's another doc in Southern California. So there are docs who are willing to be known as the doc who does it, obviously strong proponents. My sense is, in order for it to succeed, it does require the support of a team. I think no doc, it's going to be hard to do it on your own. My guess is if we did it at UCSF, we had maybe 2 or 3 docs, we had a social worker and a chaplain and a nurse together working as a team who are evaluating patients. I think that would work well. My guess also is it's a little bit of sort of getting used to it. And it's really new, and my guess is that when we started withdrawing life-sustaining interventions, it was like that as well, and there were a couple docs in the ICU willing to do it, and maybe many who didn't. I wasn't practicing then, so I don't know, but I'm just guessing. And then over time, now everybody does it. And my guess is that it may just be a process of becoming more comfortable, having more experience with it. That's my thought.
I only wanted to add that in our experience, we do have physicians who are willing to prescribe and willing to prescribe for other physicians' patients. So while they're not kind of known as the go-to, they what has happened is that there's debriefing after each basically process of PAD, and our physicians who have served as prescribers for other physicians' patients have offered to be basically their resources and for physicians, attending physicians who are prescribing. It is something that's it's an uncommon, it's very, very rare. And so for our physicians who've done this multiple times, they actually reach out and offer themselves as resources to guide physicians.
Great. In the middle?
Hi there. My name is Lisa Vigil-Schattinger. I have somewhat of a unique set of experiences to bring. I have, it just so happens that my father ended his own life when I was a toddler. And then 45 years later, my stepfather used Oregon's Death with Dignity Act. And so I will say that those two experiences, this speaks to yesterday's talks a little more, were absolutely unique experiences in that there's no comparison to the experiences and the events and the consequences in our world. My stepfather was a retired neurologist. He was 74 years old, so he was a well-educated white guy. He checked all those boxes. He enrolled in hospice. He did have an incredibly peaceful death, for which our family was incredibly thankful. So I've gone on to form a group called Ohio End of Life Options to talk about this in Ohio, of all places. I joined the board of Death with Dignity National Center, but I fully welcome this conversation and the ability to see everybody's viewpoints. And I think that I just really want to stress the value of this collaborative process in making systems that work for all people experiencing this, because I found, for me personally, living in Ohio, there was kind of a battle in the intellectual support of my stepfather versus the emotional, in knowing very well that he was going to be dying soon using this process. And also because he was terminally ill. And then throwing into that sort of the logistics. You know, what happens with that, finding the pharmacist and learning about how to use the medication and the timing of all of it. And so developing those systems throughout the different medical systems and having a collaborative process overall to help in this, I just think is so valuable. And so I want to stress from somebody who's been there that this is valuable, and I'm just so appreciative. I got quite emotional with your presentation, Dr. Pasternak, so thank you with that.
Thank you. Over here.
So my question is around, I'm very interested in the legacy of health disparity in this country and how that's impacting the uptake of these physician-assisted dying laws. So I'm curious for the DC population. My understanding is DC is about 49% African American, and the recent law got passed with a largely African American council supporting it, and was signed into law by an African American mayor. So what tipped in DC? Why?
Jeffrey?
Thank you for the question. I can't speak to DC specifically. And again, my comments were more about relative differences than absolute differences. There's certainly many people in the white demographic that don't support PAD, and many in the African American community that do. It's just relative differences. So I can't speak to the Washington D.C. specifically, but I think it's important for us to understand all the drivers of interest on both sides, and what are the features of the different communities that are behind interest in supporting PED or opposition, because it may have reverberations more broadly for healthcare, quality of healthcare and outcomes.
The middle here.
Yep. Hi, I'm Chris Kearney. I'm the medical director for palliative medicine for MedStar. So we're in the district and we're in Baltimore. So to your question, it wasn't my question, but I'm curious myself. People in this room may know better than I, but I was pretty surprised. The council voted, and it wasn't a referendum in D.C. I wondered if it was a referendum in D.C. My work in Baltimore or PG County would tell me this would not have passed in all likelihood. But I thank Jeff for your comments, because I will now be curious to see how it works out and how the distrust that already exists, whether that is magnified. So for palliative care, we are worried about the bright line. Of course, our board, MedStar, has not decided whether they're in or out yet, but the one thing they have said is that no one should request aid in dying for the lack of good palliative care. So that may be helpful for us. 2 points or 2 questions, I guess, is why wouldn't we mandate hospice care for these patients instead of a psychiatrist, for instance, and most of our patients are dying in hospice care anyway. And number 2, I guess it has to do with this article. This was the Annals of Internal Medicine in September, where it says, and this may be talked about in the next section, the Royal Dutch Medical Society led the way in addressing by having specialized panels, essentially. We could call them death panels, I suppose. But why wouldn't we do that in the United States? Why wouldn't people who do this professionally, regularly, with standards, why are any of our medical societies supporting us in this lonely activity? So anybody can answer.
Anybody who wants to respond, just ask you to be brief.
I'll just speak to the psychiatry psychologist referral. It really was in response to the sense that there are very few of them in the states that had a lot of experience, and the sense that there's probably a lot more kind of mental health issues out there that need to be addressed, and a concern of just including a safeguard for patients with a. The policy really was meant to be reviewed annually to see sort of what's happening as a result of the psychological referrals, to see whether it's something we should continue or not. So it was really a safeguard put in place for patients.
Thank you very much to the wonderful panel, and invite my former colleague from Duke, Dr. Richard Payne, to come up and lead the next group.